Good evening, everyone. On behalf of SwissNGM, I'd like to welcome you all to the first SwissNGM webinar, Dysphagia Diagnostic Approach. And today will be Dr. Ioannis, Linas, myself speaking, and then Lucas Balziger, currently in Leuven, helped organize this and will also be part of the moderation team. We will wait one more minute to get some more people entering into this session. We are recording the talk, so that's fine with everyone. And please, if you have any questions, then have those within the chat function, and we will do questions and answer questions and discuss after each part. All right, Lucas, will you do us the honors?
Sure. Also from my side, a very warm welcome to this first webinar on behalf of SwissNGM. We have put together a program for a webinar series, actually, that will start today, tackling common clinical challenges that we face and trying to give a very practical approach on how to approach these. Thank you to Isabella Schweitzer for assisting us in organizing this, and a special thanks to LaserMed for sponsoring this event tonight. We will start the talk on the dysphagia diagnostic approach and how to start the workup with Dr. Ioannis Linas. He's a gastroenterologist in the GI group practice in Bern and Hirslanden campus Bern. And as Daniel has said, after his talk, we will be taking questions through the chat function. Before we go on to the second part, please, Ioannis, the mic is yours.
Thank you, Lucas. So, and a third warm welcome from my side in this webinar. So dysphagia is a topic that's very dear to me because I've been involved with functional diagnostics since the beginning of my training in gastroenterology. And I think, so I've started with the full slide of the workup because I think the guidelines and the evidence in the whole field of dysphagia are very fractionated at the moment. So if you look through the literature, you'll find some guidance for dysphagia in Parkinson's disease, in stroke, in achalasia, or in eosinophilic esophagitis. But there is only one guideline that tried to combine it all in 2014. But actually says more the gastroenterologist side than really the whole view. And what I tried to do with this workshop is to put together information that's mostly available in reviews and expert opinions. And that's actually my way of treating patients with dysphagia. It's of course up to debate, up to discussion. So let's dive in, and in the end, you can ask me questions or present me your opinion on the matter. So, patient presenting with dysphagia, I mean, we are mostly gastroenterologists in this group. I don't have to say much. We know what dysphagia is. It's defined as difficulty with swallowing or abnormal swallowing. It affects about 3% of the general population at some point in their life and has a significant impact on the quality of life. So I won't go in further there. So I think that it's very important to understand that many patients that are referred from primary care or that they are somehow labeled with dysphagia don't actually have dysphagia. I think every gastroenterologist has made this experience at some point. So what we want to do, the first thing we want to do with the history of the patient is to confirm that he actually has dysphagia or some kind of differential diagnosis. So the patients, of course, they don't come to us and say, doctor, I have dysphagia. They usually say, I have trouble eating, or my meals get blocked, or I cannot eat normally anymore. The food comes up again, and things like that. And then we have to distinguish what exactly happens there. So we have to make the patient, to force him to tell us the whole story. For that, I'm sorry for the loaded slide. I use a series of questions, and I try to understand at which point in a meal the symptoms come, and if he can continue eating or not, what else happens with the symptoms, and what kind of meals provoke the symptoms. So these are my questions. Do the symptoms appear with the first few bites, with the first couple of swallows, or rather in the second half of the meal? Are the symptoms worse with liquids or solids? Does the patient cough or regurgitate through his nose during swallowing? Does he vomit, and at which point? And if he vomits, does he have retching, or is it rather a rumination or a regurgitation what he has? Is there a pressure or the sensation of a blockade, of an obstruction, and at which level? Is it rather at the pharyngeal level, or retrosternally, or epigastrically? And can he continue eating when this happens, or does he have to stop? What does he have to do? Is there an epigastric fullness after the meals? And how long has he had the symptoms? Did he lose any weight? So there are many questions, but with these questions, you can group the patient. You can like I would say, create a map, a puzzle of the history, and then according to this puzzle, you can use it to group the patient into certain groups and navigate the workup that you have to do afterwards. So that are the symptoms presenting, the most important presenting symptoms in the patients that are referred to us with dysphagia. There are symptoms from the upper GI tract, from the lower GI tract, also from the pharyngolaryngeal regions like dysphonia or foreign body cessation in the upper esophagus, or coughing or nasal regurgitation. And of course, important is to know what, if the onset is chronic, acute, if there's weight loss, where is the obstruction, if there is the feeling of obstruction, and what kind of foods are triggering it. So the first thing I try is to group the patients into 4 groups, to divide them into 4 groups. The first group would be the patients that have symptoms rather late in the meal, in the second half or later, that have epigastric fullness. Maybe they have nausea and vomiting, and these are patients that could primarily have dyspepsia or gastroparesis. The second group would be patients that are regurgitating food in the second half of the meal or later, without actually retching, so without actually vomiting. They may or may not have other reflux symptoms like heartburn, so these patients could have gastroesophageal reflux or rumination syndrome. And another group would be patients that do have a feeling of obstruction, like a foreign body, but they still can continue eating. And these would be the patients that likely have globus. And of course, the group that we want to identify, the most important one, is the patients that have symptoms with solids or liquids early in the meal or after the first few bites, with or without retrosternal pressure, and they have the sensation of a blockade, and that's the patients with true dysphagia. So that would be, for example, the map of the symptoms for the patients I would classify as dyspepsia or gastroparesis, that have above all a postprandial fullness and vomiting, and they can have a chronic onset, a weight loss. They can have reflux symptoms or non-acidic regurgitation, and may have regurgitation long after meal. That would be the patients that actually have gastroesophageal reflux, not necessarily dysphagia. That would be the patients with rumination syndrome that have acidic or non-acidic regurgitation long after the meal without retching or vomiting. And that would be the patients with globus. So I would be careful not to classify these patients as having dysphagia, although they are very often referred to us as dysphagia, because the workup is not the same. Of course, there are many limitations in my approach, like, for example, patients with achalasia or pseudoachalasia because of an obstruction. They can have a mega esophagus and accommodate up to a portion in their esophagus. So you may feel they have dyspepsia or gastroparesis, but they actually do have an esophageal problem. There's, of course, overlap between true dyspepsia and some of these conditions. There are times where the differentiation is not possible because the patient could be cognitive, not very fit, and cannot describe his symptoms very exactly. And of course, there are times where the bolus transit is dependent on consistency in posture. So sometimes normal people have symptoms of dysphagia, and otherwise people with conditions provoking dysphagia have a compensatory behavior. They avoid solids or they change their meals, and they don't have the typical symptoms anymore that we're searching. So we have to be careful not to miss this patient. So if we decide, okay, this patient seems to have dysphagia, the next step would be to localize the obstruction. So where do we think that the problem is? And we all know this classification in oropharyngeal or esophageal dysphagia. In the first group, the patients tend to have more problems with liquids than with solids. They tend to have coughing, aspirations during swallowing, or nasal regurgitation, or and they don't have the sensation that the food is blocked in the chest, typically. And of course, in this group, we want to involve colleagues from the otorhinolaryngology or maybe neurology, if we have the impression that the patient could have Parkinson's disease, or could be a consequence of a stroke or some other neurological morbidity. And if we're in doubt, then we can order imaging. Very often, a barium swallow or a video fluoroscopy of the pharynx and the esophagus will help there. And if we work with a good logopedic who is specialized on dysphagia, or with a physiotherapist, then we can involve them, and their assessment can be really, really helpful many times. And the second group is, of course, the patients that have problems with solids and liquids. The solids are at least as important as the liquids, if not more important. They don't have coughing, or they don't have immediate regurgitation. They can have immediate, regurgitation or nighttime regurgitation, like in achalasia. They do have the sensation that the food blocks epigastrically or in the chest. And these are the patients where we want to go on with a gastroscopy as the first test. So there are also more limitations in this approach, like the Zenker's diverticulum or the cricopharyngeal dysfunction, or the cricopharyngeal bar, as we call it. They tend to share symptoms of both categories, so we have to be a little bit more careful there. And there are patients that actually feel the obstruction at the level of the upper esophagus, or maybe the pharynx, but they actually have an obstruction in the esophagus. That's the case in 30% of the patients with obstruction in the esophagus. And of course, what can confuse us sometimes is that patients that have a problem initially with solids, they can't pass liquids afterwards, after the onset of the dysphagia. So what we want to ask them is what kind of foods initiate the problem, not what kind of foods they can swallow afterwards. So that would be the typical map. So it's the same map, but with other symptoms. For patients with oropharyngeal dysphagia, you see the differential diagnosis, mostly neurologic conditions, but not only. And if we have such a patient, like I said, we have to involve other colleagues. And if we're in doubt, then we can order an imaging. And I'll show you a video that helped me out recently. That was a patient with signs of oropharyngeal dysphagia. But if you see the video, I've played it back and forth. There's here, if you see my cursor, liquids staying obstructed above the upper esophageal sphincter, which is highly contracted during swallowing. That's a Zenker's diverticle with a cricopharyngeal bar. We can see it if I turn back. So that's the bar here, and we have the Zenker's diverticle here. So imaging can help us in these cases. And that's the symptoms of patients with a Zenker's diverticulum, which shares a little bit of both conditions. Of course, then we have the typical patients with a mechanical obstruction, that are the patients that have more problems with solids than with liquids. They can have retrosternal epigastric sensation of obstruction, but like I said, it could be also cervical for some of these patients, and they do have regurgitation mostly in the first few bites or early in the meal. And of course, if these patients have also an acute onset and a weight loss, then we should be careful about cancer. If they don't have that, but they have an atopic history, then of course that could be an eosinophilic esophagitis based on the history. And if they have equally problems with solids and liquids, a diffuse retrosteral cessation of obstruction and a chronic onset, that could be a motility disorder based only on the symptoms. That's the typical presentation of achalasia. So it's like a motility disorder, but in addition, regurgitation log after meal, maybe at night when they lie down, and aspirations. And if we have such a patient, so we have the impression he has an esophageal problem, then the next test would be the gastroscopy with biopsies from the esophagus. And why gastroscopies? I mean, I don't need to preach to the gastroenterologists about that, but dysphagia is an alarm symptom. 0.9% of the patients will end up having a malignancy. So the ones that are referred for a gastroscopy with dysphagia. And the gastroscopy lets us directly visualize strictures, rings, features of eosinophilic esophagitis, other kinds of esophagitis, Barrett's esophagus. Let us take biopsies to identify infections, metaplasia, malignancy, and we can do a dilation at the same session if we need it. And of course, if we have the expertise and the tools, then we can do other examinations at the same time, like an endoflip that Daniel is going to show afterwards, or an endosonography, or a Bravo capsule pH study, and we can identify other conditions that can mimic dysphagia. So what we see in the gastroscopy, I mean, maybe you all have seen these images many times. So cancer is the first thing we fear and the first thing we want to exclude. That was a patient that I saw this week, actually diagnosed with an esophageal cancer, and I had the opportunity to do so these images are from this patient, and I had the opportunity to do the endosonography at the same stage, so that could show a T3N2 cancer. Sorry. That's the patient with eosinophilic esophagitis. Again, the images are from this week here, so that common problems that we see again and again. We can recognize the typical signs of it, the rings, the furrows, the exudates here. That's a mucosal tear after inserting the endoscope simply. That's an old case. And here a stricture. Sorry, what's the chat? Here's a stricture, and the same features again in another patient. And we can have strictures of other kinds. That's a post-radiofrequency ablation stricture, which I saw recently. The treatment was given many months ago, and again, strictures because of an esophagitis, a reflux esophagitis. And if there is no severe inflammation, we can do the dilation at the same session and offer some kind of treatment to the patient directly. These are esophageal webs in the proximal esophagus. Again, a recent case which we could treat at the same session. And infections, so that's a candida esophagitis. You all have seen it. It can be mild or severe, as in this patient that affected the whole of the esophagus. And then, of course, reflux could be itself a reason for dysphagia, even without strictures, because of the esophagitis at the distal esophagus. That's a mild esophagitis, a more severe esophagitis. You all know these pictures. And of course, we can have indirect signs of a motility disorder, like an achalasia here. That's an old patient, an ancient patient of mine with an achalasia, where you can see the diverticulum and the very tightly closed gastroesophageal junction. Again, a tightly closed gastroesophageal junction with a dilated esophagus in another patient. Of course, it's not confirmatory of an achalasia, but that prompts us to think in this direction. And something more rare, at least in my practice, is a post-actinic esophagitis. But of course, sometimes the gastroscopy can be totally normal, and still the patient is experiencing dysphagia, and we think it's an esophageal dysphagia. And then we have to think what happens next. And in that case, for me, the main question is, do I have the possibility to conduct functional diagnostics here, or to refer the patient for functional diagnostics? And of course, that has to do with availability. So do I have a colleague that can do it in the next weeks? Do I have a referral center where I can send my patient? I think in Switzerland, it shouldn't be a problem in most cases. For me, at least, it's not a problem because I do it myself, but still there are patients that are not really suitable for functional diagnostics. And if we have this case, then the next best examination would be imaging. So that was, for example, an elderly, morbid patient with severe dysphagia. For many months, he could practically only drink, not eat anything. He had lost much weight. And in gastroscopy, I didn't have any possible explanation. The biopsies were normal, of course, and I didn't want to subdue this patient to a manometry that bring him to the private practice and then run a manometry in his frail condition. And that's why I decided to do a barium swallow. And what we see here is what we saw for the whole duration of the study. The patient could not actually clear the contrast agent, and we see signs of tertiary peristaltism and of esophageal contractions. And the next thing I did, which Daniel will show again afterwards, is an endoflip, which also was compatible with dysphagia. And then we decided, even in the absence of the manometry, to provide esoflip dilations, which actually led to a remission. So again, that would be my workup for patients with dysphagia. For all the rest that are suitable for functional diagnostics with a normal endoscopy, I would refer them for functional diagnostics, for manometry primarily. And there's nobody who can explain us better what we do when we conduct functional diagnostics than Daniel. So I will pass the microphone and the stage to Daniel, who will talk about that. Except if there are questions for me, I would be happy to answer them also now.
Yeah, thank you, Ioannis. This was a great start. Thank you so much for putting that together. So Lucas and I will moderate that now and ask a few questions. Lucas, do you want to go ahead? And then please, everyone, if you have something in the chat, then you can also obviously put your question into the message, and Ioannis can read it, or we can read it for him if he doesn't see it.
So thank you very much, Ioannis, for this great overview. While we are waiting for the others to add their questions to the chat, I maybe have maybe a stupid question from a gastroenterologist's point of view, but you said that many patients that are actually addressed to our care do not actually have dysphagia when we further question them. But in this setting, is there any reason for you not to do a gastroscopy in these patients, with whether they have dysphagia or other upper GI complaints? Is there a situation where you say, based on history taking alone, I will not do a gastroscopy?
Well, it depends. I mean, you won't harm them with the gastroscopy. You will subdue them to a sedation, of course, and to the slight risks that a gastroscopy has. But the patients are often not referred for a gastroscopy. So they're often referred in our outpatient department. And then, I mean, I have a waiting list for, at least in my practice, for a gastroscopy. So that would actually set me back in the workup of this patient. And if that's the case, and I don't see a real reason to do the gastroscopy, I really think that the problem is, for example, oropharyngeal dysphagia or something totally different, then I won't do it. Again, if I'm in doubt, I would do the imaging. That would give me also time to think. Often, if I have the impression, even from the referral, that the patient actually does have dysphagia, then I will schedule him directly for a gastroscopy, because, as you say, when we won't actually harm them, and then we can exclude a couple of things. Sometimes it will be a normal gastroscopy that won't help us further, but that provides a little bit of information in itself. But if you see the patient, for example, in the primary care, because there are also some internists in our group, if you see the patient in your outpatient department, in the emergency department, then I'm not sure that the gastroscopy is always invariably the next best thing to do if you don't have the impression that the patient actually has true dysphagia. So, I mean, if I have the impression that he has regurgitation or that he has gastroesophageal reflux, I would probably try PPIs before referring him for a gastroscopy. So that's my honest answer there.
I like your approach, Ioannis. I think it's very primary care oriented always, what you do, because you test and treat. This is not a usual gastroenterologist response, if I may add. I guess the reflex typically would be to not really select at this point in time which kind of diagnostics are needed other than primarily an upper endoscopy. So it's interesting that you say that, and it's interesting to see that there's different evaluations of this out there.
I think it depends on the setting. Is it the outpatient department? Is it the emergency department? And then also it depends on how fast you can get a gastroscopy practically.
Yeah, true. So, Ioannis, maybe like to have your opinion on barium swallows, because I don't know how it is in your practice, but the interests of radiologists in both fluoroscopies and barium swallows is not huge. And what I've experienced, that if I get referrals from other places which include these, that usually I cannot do much with them. So I'd like to know your opinion about that, and also if you have an idea of how we make this better, or how you deal with this.
I think we have the same impression here, because actually, I mean, barium swallow is something that is validated. I mean, the timed barium swallow is a 5-minute study. It's something that there's a certain protocol and it's validated, but the chances, if you refer somebody for dysphagia in a radiologic institute that it's not a tertiary center, the chances are very high that you will get some kind of video fluoroscopy, maybe with gastrographin, maybe with barium, maybe liquid, maybe viscous, maybe solid. So it depends on the expertise. I think we have to be exact on what we want when we refer patients. So I'm writing explicitly timed barium swallow, and then I usually get the answers I want. And we have to be exact at what kind of contrast agent, which viscosity we want. For example, in my center, I've talked with a radiologist, and we do barium and the barium capsule at the same time. So we give both to the patient, and that's what we do with suspicion of achalasia. Of course, there are conditions where I have the impression it could be something else, where I would prefer something more viscous, like, for example, mashed potatoes with contrast agent, which is also something we do. But then I have to be specific about what we want. In general, like I said, I don't order imaging very often. So I think a very good manometry can confirm far more things than imaging. So barium, if it's normal, then the chances that manometry is normal are also there. If it's abnormal, manometry could be normal or could show a motility disorder. So I prefer the manometry because the specificity is much higher than the barium swallow. So I do it only exceptionally in patients where the manometry is not conclusive, which is not very frequent with the Chicago 4 classification, or in cases where I cannot or I do not want to do the manometer because there's a contraindication, like a previous perforation, a Zenker's diverticulum, or because the patient is very frail, he cannot tolerate the tube. So that's a problem I have from time to time. The patients have really, really enormous reflexes, and even if I do adequate analgesia and anesthesia, they cannot tolerate the placement of the manometer probe. But that's rare, but it can happen. So that's where I do actually imaging.
Okay.
Excellent. Thank you so much, Ioannis. I think everything was clear. Now comes just a question when I want to wrap it up. Dr. Tutian asks, maybe a stupid question, but what do you do with patients with severe dysphagia without any cause found? Negative gastroscopy, nothing on barium, nothing on manometry, or maximum ineffective motility, no response after empirical dilation. Have you ever tried a dilatation like for achalasia, 30 millimeters, even without actually the diagnosis of achalasia, or would that be too much?
Well, if it's for me, yes, I've actually tried that. So the answer would be I do an endoflip for these patients. And I often have a discrepancy between the end of lip and the manometry. That means the manometry does show peristaltism, so normal peristaltism, with or without complete relaxation of the lower esophageal sphincter, which actually precludes achalasia. But in the end of lip, I do have a very low distensibility, which is an argument for achalasia. I don't know actually how to classify these patients. That's my honest opinion. I think they could have a beginning form of achalasia that would develop over time or not, but I have dilated such patients with an achalasia protocol and it had helped. So I've had such cases and it helped. So the dilation helped. I'm not sure I would do it with a normal end of lip, but I actually do an end of lip as a next step there, but Daniel will talk about it, I'm sure.
Yeah, I'll talk about that, and then obviously, and we will have a second webinar in January where we'll talk about therapeutics. So I think we will. I think this is a very good question, Georgiana, and I think we can take that back up and discuss that, because these patients obviously exist. But having said that, having introduced or having been able to introduce manometry and then also end of lip into the picture, and also expanded on the metrics that we use for manometry and the maneuvers that we use. And there are very few patients where you don't find anything. So the diagnosis of functional dysphagia has become very, very rare. And this was very different just a few years ago, in my opinion.
And I think this question sets the stage perfectly for the second talk, which will be given by Professor Daniel Pohl, who is a staff gastroenterologist at the University Hospital of Zurich and responsible for the Neurogastroenterology and motility unit there. And he will talk about the workup following what we have done, discussed with Dr. Linas, the beginning of the workup, what is done then in a specialized neurogastroenterology motility clinic. Please, Daniel, the stage is yours.
Very well. I'm putting up my slides. And I hope you guys will be able to see this very soon. Okay, perfect. So thank you, Lucas, for that. And also, again, thank you, Ioannis, for setting the stage. And I think you showed us very well what endoscopy and possibly imaging can do. However, there's also the truth that if you do that, then you identify the cause of dysphagia in actually less than a third of patients. So endoscopy is great, histology is great, it's important, it's needed, but we do need more, because most of our patients have dysphagia which is not readily clear on endoscopy and or barium swallow. So I'll come to discuss two matters with you today. One is first the high resolution manometry. I'll skip a few of the standards, but go right into how we diagnose different disease states in manometry these days. And currently, most centers in Switzerland, probably all centers, are using what is called high resolution manometry with 32 or 36 channels. And what really manometry does, or was developed as, it was developed so that objective parameters were validated against esophageal function, which means that bolus transport was deducted by manometric pressures. So we are measuring pressures, and by the normal values that we have, we deduct what actually works or how the esophagus functions. And usually and classically, this has been done in the supine, not in the upright position, using small volume water swallows. This is how it was in the past, also on standard low resolution manometry. And then the Chicago classification came along. We currently have the fourth iteration in place, and then the fifth is being in the making, or it's just getting started to be in the making, actually. And it's really about two things. It looks at the physiological principles of function or dysfunction at the esophagogastric junction, so right above the stomach, and the dysfunction of the tubular esophagus itself, especially peristalsis. So this is the only slide in German. It's from a recent review that a fellow of mine put together. and where we talk about the Chicago classification. And again, these are really the two pillars that we talk about: the EGJ outflow obstruction, or the EGJ disorders, and the peristaltic disorders. And if you start on the left, because that's the more prominent disorders, which are more readily clear, which are usually more symptomatic, where there's more data on how to treat them, except for EGJ-OO, which is a difficult one. And that's the three subtypes of achalasia, and I'll explain to you what those are. So here we're covering what's wrong at the EGJ. Is the integrated relaxation pressure high or not? And then we're looking at the peristaltic disorders, which are much more difficult to discern. We look at something like spasm. Used to be called diffuse, now we call it distal esophageal spasm. Then the hypercontractile esophagus used to be the nutcracker, the jackhammer. This has been reworded a little bit. And actually the nutcracker is not being considered a real entity anymore. And then there's the still not so easy, but more clear ineffective esophageal motility, and then the complete lack of peristalsis, aperistalsis. So let's look at how we diagnose achalasia. And really, I think there's still no discussion that high-resolution manometry is the gold standard in, number one, diagnosing achalasia, and number two, subtyping achalasia into type 1, type 2, and type 3. And these are typical images that you see. Starting on the left, you see here this color-coded image. You see the upper esophageal sphincter, you see the lower esophageal sphincter, and here there's a pharyngeal opening. But, however, there is no relaxation here of the. Sorry, I have to get some people inside the meeting, doing two things at a time. There's no relaxation of the lower esophageal sphincter. There's also no real pressurization here. This is probably because the esophagus is already largely as wide, and you can see neither contraction of the longitudinal nor the circular muscle. Now, the type 2 patients are the patients usually not that long-standing disease. The esophagus is more tight. It can still pressurize the manometric catheter, which obviously is a thin catheter hanging in the esophageal lumen, and then you can see these pressure bars forming. And so this is a classic achalasia type 2 patients. And then you have the, I would say, more rare than usually diagnosed, because often misdiagnosed, achalasia type 3 patients, where you do not have sufficient opening of the lower esophageal function. You do have a simultaneous pressure front. You do have higher fronts. You have maybe some more or less peristaltic activity at the end, but not at the front. And these patients are always a matter of debate whether they fall into the realm of achalasia type 3 or EGJ outflow obstruction. So if you do the barium, this actually does correlate with findings type 1 and type 2. Maybe type 2 and type 3 actually do look rather similar. Type 3 maybe a little bit more spastic at times, but type 1 are usually the ones that have a really large esophagus that also, Ioannis mentioned, they also may be asymptomatic for that reason, because their esophagus is not a transport organ anymore. It's a reservoir organ as the stomach, and this is something we need to change unless we don't want the esophagus to stop working in a few years. And in type 2, it's tighter. There's still some contraction of the longitudinal muscle. And obviously, gravity is the most discerning factor that helps us get the food down into the stomach. Now, I'll give you a small case. This is a large patient, 2 meters and 5 centimeters tall. He'd been seen by 3 external gastroenterologists for retrosternal pain, and they did find sore esophagus. Each time they scoped in and they treated it, didn't have any immune dysfunction that was apparent. Healthy guy, no diabetes or anything. Patient came to us and we did a esophageal manometry, and you can see here on the water swallow, we could hardly get both sphincters onto the catheter because he was so tall and had such a long esophagus. But you can see here that the upper esophageal sphincter opens upon deglutition. It's a little bit of a pressurization here, and there's visually there's not sufficient opening of the LES. However, even if we place down the catheter a little bit more to equate for the normalization with the stomach pressures, the IRP was normal. So we have this patient that doesn't have peristalsis, visually maybe not so much opening, but IRP is normal. So it doesn't fit into our Chicago realm, certainly not into the new one, where the IRP we are using a Medtronic device would be 12, at least in an upright patient. So we gave the patient a test meal, and you can see, giving him the test meal, that there's a little bit more pressure activity. So by the way, you can make every achalasia type 1 and type 2 if you just give them enough to eat. So place your diagnosis still on single swallows, but use the rice meal then to get additional information into the diagnosis of the patient. And you can see that actually there is some stasis here in the esophagus, seeing that the rice gets stuck. And if the patient eats more rice, this is also more getting stuck here. So there was bolus stasis. There was also here no residual peristaltic activity. Sometimes we can get patients who do look like they have no peristalsis in singular swallows, the water swallows. We can get them to have peristalsis, which then obviously questions the diagnosis of, for example, achalasia. So this is something to also look for. We did an endoflip in this patient. And after having done that, the distensibility on this particular patient, still with the endoflip 1, was at 2.1, which is in the lower range. For Chicago, this would be clearly abnormal. They say below 3, we say below 2, and 2 between 2 and 3 is borderline. So clearly, for us, this was not normal at the time. So we did a barium swallow. We like to do the timed barium swallows. We give the radiologists exactly the instructions how to do that. We actually wrote down the protocol together with them, and now they're teaching all the fellows and have been doing that. So I think this is a way to go. And then you see here the 5-minute picture on the left. You see that there is stasis after 5 minutes. Again, the patient only is symptomatic for retrosternal pain and the sore that I said. And we treated him. We dilated him back then twice. This was pre me using the EsoFlip. I used a Rigiflex device twice, 30 and 35 millimeters. And you see after the second dilatation that actually there was no more residual, also again here at the 5-minute window. So EndoFlip helped us identify this patient, which helped us treat. Now I can hear myself twice. No, it's over. Good, good, good. All right, let's go for diagnosis of the obstruction of the GE function at the EGJ. And this is more difficult. If you have IRP, look at this patient in other centers may be diagnosed as an achalasia patient. But however, this patient did have a tight fundoplication. And this was the reason for the EGJ not opening properly and looking front like it was kind of like a peristalsis. But here it's an EGJ outflow obstruction due to a tight fundoplication. And then you have these patients. They open up, not really, possibly here, but then there's also severe esophageal shortening. This is probably not peristalsis, but some residual achalasia. Is it an achalasia variant? Is it EGJ-00? Well, the patient is, we call him EGJ-00, and the patient is symptomatic. So we follow up these patients. Again, this is a much more difficult entity to deal with. And this is also one where I like to have an additional, or two actually additional diagnostic tools to better characterize the function in these esophagi. Now, we did a study where we looked at opioid consumptions in patients who have EGJ-00, because having seen a lot of these EGJ-00 patients, we found that looking through their to their charge, actually a number of them were using opioids. So we looked at that, and actually, yes, there was a significantly higher prevalence of opioid consumption with EGJ-00 as compared to other outflow obstructions. The mechanisms here are complex. They're generally mediated through inhibitory effects that interrupt the neuronal and neuroeffector transmission. Also, possibly the inhibition of nitric oxide release, which usually relaxes the lower esophageal sphincters, so the DCI becomes higher, also the tonicity of the muscles. So this is something to look at. If you have EGJ-00, definitely look again at the medication that the patient ask them if there are any sort of substitution to really rule out that they are on opioids. All right, now we come to the diagnosis of a spasm. This is something that has also changed over the years. We used to look at peristaltic front velocity, which I personally liked. Now we look at what we call latency. latency, meaning the initiation of the swallow until the deceleration of the curve. And this is a patient where this is normal. You have a long latency between the initiation of the swallow and the deceleration of the curve, which starts around here. Here we have 5.9 seconds, and the setup here is if it's more than 4.5 seconds, it's normal. And here you have patients where this is not the case. This latency is short. Important here, IRP is below 15. If it's above 15, it's not spasm, it's EGJ-OO. So that still tops basically the peristaltic activities. Now about hypercontractile esophagus. We do have these patients that we used to call jackhammer, who do have crazy high amplitudes in the DCI. And still, you need at least 2 out of your 10 water swallows, not the test meals. In a test meal, you can more easily identify these patients, but obviously there's no data on that yet. What we make out of those. But using your water swallows, if you see this, you have 2 swallows. We have this very high distal contractile index, and this is a patient that has jackhammer esophagus. Sorry, hypercontractile esophagus. Now, ineffective motility, this has become a little bit more strict. If you have more than 70%, it's now larger than a 5 centimeter break where the DCI is above 450, or more than 70 where the DCI is between 100 and 450, then this is ineffective. Or more than 50% less than 150, so very low. Aperistalsis is currently 100% DCI lower than 100 millimeters. So this has become a little bit more strict overall. And it's still the most questionable diagnosis of all, and the most difficult to deal with. Usually patients who have scleroderma or other rheumatologic disease or long-standing severe reflux disease. Now, what's important is that having done HRM for some time, we used for some years different viscosities to look at what's best for these patients. Another maneuver are these so-called multiple repeated swallows. There's also the rapid drink challenge. So these are 2 different entities that you may use to look at what's going on at the EGJ level, also from a neuronal level. Is there complete inhibition? Is there, if the patient drinks, also some sort of post-EGJ after contraction? Is there a clearing contraction, which you do not see in this patient? So this is a pathologic swallow, and this may be helpful in patients with reflux. And then the test meal, which I personally look at more, because that's what patients do. They just don't drink small sips of water. They do eat, and rice is perfect for that if you use that as a test meal, because it's culturally unproblematic. There's no allergies virtually, and it's so cheap, available all over the world. So we use a lot of rice. Our patients have to eat rice within 8 minutes, a certain amount of rice. And then we look what's happening. And very often you find patients that look completely symptomatic, patients that look completely normal on singular swallows. And then you challenge them a little bit, and you can see they get the spastic activity, which in the end then does explain their symptoms. And obstruction of the EGJ is the most frequently missed findings. Now, if you want some reading done, this is still the current and valid Chicago classification, which is being used all over the world, version 4.0. I'm not going to go through the details here. I think we've looked at a number of these things, but this is, I think, excellent literature for you to look up at home. So there's terminology, but the question is there room for improvement? And I just mentioned to you, it's the current state of the art to diagnose achalasia and to characterize esophageal motor activity. And I showed you that what it does, it measures pressures. These pressures are supposed to tell us something about wall, about movement in the esophagus, about a transport of the esophagus. However, bolus transit really is directly related to the wall stiffness and how narrow the lumen gets. And how narrow the lumen gets, we don't know by manometry because the catheter is simply too thin for that. So it does lack the ability to fully assess what are called pressure geometric data. So this is, I would say, a rather nice review that we put together some years ago, looking at what FLIP does, FLIP 1 and FLIP 2. And again, it's something that can be used in real time in the patient while he's being scoped, and it assesses the narrowest area along 16 recording sites in the esophagus. And then you kind of get a picture like in an HRM However, please be mindful that this is not a manometry pattern. This is diameter translated into a color coding. And flip 1 was excellent for looking at sphincters. I also used it for the tubular esophagus simply by pulling it back and then doing a second series of measurements. But the term panometry was coined by the very active Chicago group here on the topic then, where you look at the EGJ and at the tubular esophagus at the same time. So a number of endoscopies, up to 20% actually, are done for the evaluation of dysphagia. And as I told you, there are a relevant number of upper endoscopies that don't show why. I'm sorry, I have to look. Isabella, could you please make sure that all the microphones are muted?
Yes, unfortunately, I can't. You
Okay.
have to do it.
Sorry about that.
Sorry.
I have to go out of this. So yeah, maybe everyone who's in there, there's 1 or 2 people that maybe have their screens still on, their microphone still on. Yeah, DS, for example. Again, ENOFLIP does add physical imaging to the optical imaging. It's under patients are sedated. It's great if the patient can tolerate regular manometry, and it allows the clinician to view these patterns in real time. And we look at really, nowadays, we look at patients with supposed laser EGJ outflow obstruction. Also is very nice for differentiating hernia and the size of hernias, challenge hernias to see how large they can get, look at rings and stenosis. And these patterns can also be used to assess tubular esophageal motility dysfunctions such as hypercontractile disorders, hypocontractile disorders, and aperistalsis. So I think a very important thing for us as gastrologists is to notice that esophageal narrowing is nothing what we are good at identifying with an upper endoscopy. And this is patients with eosinophilia in the esophagus, and they used a cutoff of 50 millimeters. There, the sensitivity of an upper endoscopy was 25% to find a meaningful narrowing, which was lower than 50 millimeters. So that's very, very, very poor. So actually, eosinophilic esophagitis is an excellent cause where, and this is an image where you can see that you see these strictures in the esophagus here, and this is the EGJ. And you can look at very well where's the narrowing of the esophagus, where's the more prominent part, less prominent parts. And you can look at what's called the distensibility plateau to see where the most prominent strictures are, and then you can dilate them to your liking. And I think it's very helpful in these patients. Again, if you do have a diameter lower than 17 in these patients, then this is something that you then want to send for treatment. Now, a key measure in EGJ distensibility was really identified by 2 groups, one from the US and one from Leuven. And I think this is excellent because we have 2 centers from different continents which basically come up with similar values, and that's 2.8 and 2.9. And again, currently the theme is that below 2 is normal. Some say below 3. I would say between 2 and 3 is borderline, and we still have that in our first paper, our first, I would say, expert opinion group paper, and then above 3, it's rather normal at EGJ, so you can use that. Looking at patterns, we have to learn some new patterns. There are most prominently the RACs and the RRCs. The RACs are repetitive antegrade, and there are RRCs repetitive retrograde contractions, and then there's patients who have also aperistalsis on such a flip. Now, this is more or less homework. This is a study by Dustin Carlson from the Chicago group, December 2021. This was published in the ACG, and this it's a little bit of time to look through this. Basically, there are 5 things you have to differentiate looking at the tubular esophagus, and 4 looking at the EGJ, and they look at the contractile response of the esophagus. Is it normal? Is it borderline? Is it impaired borderline? Or is it absent or spastic reactive? And for the EGJ, is it reduced opening, borderline reduced, borderline normal, or normal? And obviously, as usual in the world, the gray zone is the most difficult one. So the normal patients are not so difficult. Normal contractile ratio, normal esophageal opening, maybe also the borderline contractile ratios, but importantly then the normal esophageal opening is important, whereas the obstruction with weak contractile ratios are clearly abnormal, and also the spastic reactive, and all the ones that have basically retrograde repetitive contractions are abnormal. And those, the ones that fall into the middle, there we need to have additional thoughts. Now, if you look at some findings, I would like to correlate some HRM and some endoflip images. I'm also here from the same publication, which I think was quite nice. So let's start with A. You have these antegrade repetitive contractions. You have a DI at the EGJ of 5.1, clearly normal, diameter looks normal. This is a normal HRM. You have this patient, EGJ DI, it looks also normal. Maximum diameter also looks fine. Nothing much happened here. What's going on? Absent contractility. You have this patient, you see a little bit of disordered. Here it's retrograde, here it's antegrade. EGJ DI is low, 1.3. This could be, I think, two things. One is achalasia type 2, and the other one is EGJOO. And here you see a patient who does have shortening, sustained esophageal contractions, super low EGJ-DI. Could be also type 2 or at type 3. So I think this is quite nice, and there's nice data that actually the findings correspond in most of the cases. However, possibly even endoflip may be more suitable to identify some of the questionable HRM cases. Endoflip also allows you to respond to therapy. If you do dilation, if you have a rise in EGJ-DI by 1.8 after balloon, immediately after balloon predation, this is 87% predictive of an immediate treatment effect on the short term, I must say. There's also some data on POEM. Patients who had a better response are the ones who come out with a DI of 4.5 to 8.5. If it's lower than 3, then usually those are the ones that have a worse response. This is also true for the cross-sectional area and the compliance. And you tend to have more reflux when if your DI gets above 2.7. You have to find a medium way. And obviously, we still don't know what the perfect angles are. And one of the reasons are that endoflip is differently done in different centers, which is why it's important to use a standardized approach here. What about if HRM is unremarkable? Also some data here. 10 patients who were symptomatic. They had what they first thought was an unremarkable HRM. However, they did have a little bit of simultaneous pressurization here, but latency was normal, so they didn't really get a diagnosis out of Chicago. Maybe we need to look at those more. And follow-up, 7 out of 10 showed some, as I said, mid-vertical pressurization. Now, looking at flip, they were spastic, 7 out of 10. There you saw sustained esophageal contractions, hypercontractor or long contractions, then sustained esophageal contractions with occlusion here, shortening, so esophageal lift, and 8 out of 10 were treated and they responded to treatment, 5 Botox, 2 esoflip, and a halamyotomy. And obviously, if you have patients that are questionable, then Botox is something to discuss as an intermediate measure, but we'll look at that next time. So if I look at the diagnostic use of HRM and endoflip in the version 4.0, what does Chicago say about endoflip? Well, it's still not a lot. It's right low here at the bottom. If you have no evidence of EGJ outflow obstruction, if you are you do your swell models, you have the abnormal IRP, and you come into EGJ-OO, and then they want that you do time barium swallow or a flip. So right now it's still down here in the Chicago classification, and we'll see where that goes into the future. I have my personal endoflip dysphagia workflow here. So if you have a patient with dysphagia, you do EGD and you do biopsy at the same time. Obviously, we don't have instant biopsies yet. So we don't know if there's already an EOE. If it's very unlikely, you may consider doing an endoflip at the same time, but obviously still take the biopsies. If that is abnormal and you have a disease you have finding, then you have either mechanical obstruction or achalasia, that's fine. If you have normal esophageal opening, normal contractile response, normal diameter, no hiatal hernia larger than 3 centimeters, this patient will very, very unlikely yield any abnormal result in the future. If you don't have all of that available, then you definitely go to high-resolution manometry first. And I like to do barium swallows, but again, with a very tailored and very standardized approach. And then we see what we get out of there, and then possibly endoflip is the way to go after that if we're not clear about our diagnosis. If we already diagnose achalasia, we are fine. EJOO, I still like to do a flip. Absent peristalsis, difficult, I think needs a flip. Hypercontractile disorder may or may not. You may also work with Botox here, but usually you have a diagnosis here of a primary motor disorder. And then patients who have in-between findings, rapid contractions, IM, weak peristalsis, frequently failed, normal distensibility then already, so you do the flip, normal barium, you have to look for another cause. Or if you haven't done so, do the flip, look for GERD, and then arrive in very few patients at the diagnosis of functional dysphagia. So I'd like to conclude. High resolution remains the gold standard in diagnosing achalasia. It allows the subtyping of esophageal motor disorders, and the therapy will follow up in January of next year, 2024. We have the additional tests in HRM, which increase the sensitivity, but also the specificity of testing, multiple rapid swallow, rapid drink challenge test meal. And the NN-FLIP allows me the assessment of esophageal dysmotility and distensibility in the endoscopy suite. I believe it's useful in the assessment of strictures, doubtful achalasia, EJO, unremarkable or questionable HRM results in the symptomatic patients. Patients who don't tolerate any catheters, and it may also be used more primarily in the workup. And if there's a normal finding, it's very unlikely that there should be anything after that. So thank you for your attention, and yeah, let's see if there are any questions.
Thank you very much, Daniel, for this great overview. While we're waiting for further questions in the chat box, maybe I'll start. So you mentioned at the very end the rapid drinking challenge and the multiple rapid swallow, and you mentioned during your talk also the rice meal. Do you do all of these as standard in every patient? So the solid swallows and the multiple rapid drinking challenge and multiple rapid swallows and the rapid drinking challenge? Is that done in every patient in your practice?
So we do it in every patient that tolerates it, basically. And because we do it a lot, we are rather fast with it. We don't do a rapid drink challenge. I personally only use the multiple rapid swallows. But this is for simply taste reasons. I could also exchange that. My main thing is the test meal, which I think is very valuable. So I do that in almost all patients, unless obviously they don't tolerate it or they don't want it. Also for achalasia, I kind of like it because it gives you an idea of barium, almost like a barium swallow, gives you an idea of bolus height. You don't need it for the diagnosis, but it's nice also for the follow-up. And also it gives me an idea about the patient, how quickly he develops symptoms, also to assess how severe is that patient, how quickly do I have to treat him. So I personally do it. I don't think it's super necessary. If you do probably if you have an asymptomatic patient who has reflux disease and he comes for the assessment of reflux surgery, then probably the simple water swallows looking at hernia are enough. But if you can afford that in a lab to add these minutes to your testing, then I think you always find a patient where you were happy in the end, you found something. Oh, by the end, they did have an outflow obstruction. You look again with the flip. They already had a Schatzky rank. And then you can treat that.
Okay, we have Pohl with a question, please.
Or you have to type it, I think. Let me see if I can get you on loud.
Can I ask a question? Hi, this is Radu.
It's Radu. So Radu.
Sorry about this. I'm in a car, that's why I cannot type. Sorry, excuse me.
Sure. So Radu, go ahead, and then we'll get Pohl.
Paul, okay. 2 questions. Well, I have a lot, but I will try to resume only 2 questions. One regarding the endoflip. We always discuss this in patients with achalasia, especially when they get treated. And let's say you get a surgical myotomy with fundoplication. Can you tell by endoflip if that's still residual muscle / achalasia relapse, or if the fundoplication is too tight when patients come with dysphagia or chest pain after helermatomy plus fundoplication? So that would be question 1. Mm-hmm. And question 2, when you do the rapid swallows, we also do them very regularly. My primary assessment is whether you have a peristaltic reserve or not. What's your take on assessing the relaxation during the initial 3 or 4 swallows. How do you quantify that?
Mm-hmm. All right. So your first question was, can you differentiate residual muscle from a tight fundoplication, right?
Yes.
Yes. So I think that's super difficult if the fundoplication is exactly at the level where the sphincter was. Sometimes they're a little bit separate from each other. So you have two things. You have the fundoplication, and you can differentiate that well on the endoflip. And then you have a little bit above some muscle bridges, which are still left. And you can sometimes also see them endoscopically, but then when you endoflip, you can see them better. If they are basically above each other, I cannot. However, if the patient is symptomatic and I have an abnormal DI, let's say I have an abnormal below 2, then, and the patient is not freshly operated, by the way, I always wait the first 6 months. So they have to get used to having a more rigid, I would say, outflow, a more higher esophageal pressure. So in the first 6 months, nothing, but then I basically redilate them. But I don't think I can differentiate, is it the rep, or is inside the rep still some residual muscle? But again, I think that the consequence of me was, after a waiting period, is to redilate that fundoplication. And I do that step by step by using the esoflip, because obviously once I have dilated too much, then the fundoplication is worthless. And also, as we all know, a fundoplication gets looser over time. So I also want to give the patient a little bit of the benefit of the time there before I destroy his surgical fundoplication. And the second question, is that an answer, Radu?
No, that's a question, sort of, how do you, that answers the question, yeah. No, because I was also under imagination, because basically on the distension curve, I was thinking that you could, whether it's something that rises constantly, speaking for a muscular type constriction, or if it stays stable at a higher level, whether that can be helpful. But in that case, if you say it's not possible, then I will drop this from my question to endoflip. The second question was,
if you talk about the distensibility plateau, like in a stricture, you would say that
exactly.
the fundoplication is more tight and more rigid, and possibly it's also wider than if you just have a muscle bridge. So this is something that possibly we can look at. But I think in the end, the consequences are the same.
Yeah, because I see, for example, I see this in like say not achalasia, but regular fundoplication patients who come with dysphagia or chest pain. And when you blow up a balloon, let's say put up a 30-meter pneumatic balloon, and you try to open that, you get a fixed stricture. And regardless how much pressure you put in that balloon, you cannot overcome that stricture at 17, 18, 19 millimeters. So you know that there is something going on there which is fixed, which is probably due to the wrap, which you will probably not get like ruptured. I think we have this imagination that we can rupture the sutures, but I don't think that you can really rupture the sutures on the fundoplication. That's at least sort of, until I see one, I will. I've seen rather the other extreme. Sorry, the second question was on the multiple rapid swallows. Normally, you would expect for the esophagus to relax, and you should not have any intrabolus pressure nor contractions during the first 3-4 swallows. You should have it only at the end. How do you quantify that? Do you have any means of quantifying that?
I personally
relaxation.
No, we look at it visually, but then we see what happens in the test meal. So do you look at it with numbers?
Well, I'm trying to do that, but I don't have a base on that. So that's why I was wondering whether we should look into this and whether we should put some data together to come with a meaningful way of not just looking, but maybe we can come up with something, because multiple rapid swallows we do during every manometry. So even if they are normal or not, that's quick, and that's something that we incorporate pretty much in every patient at the end of the meal, or at the end of the 10 swallows.
Yeah. So you look more into that. I look more into the test meal, I suppose.
Okay. No, that's fair. That's yeah.
But let's talk about it aside. Obviously, putting some data together.
Sure.
Is good.
Yeah.
Paul, can you tell us?
Can you hear me?
Yes, we can hear you.
That's really unfair from Radu, because he had to my question was stolen by Radu, so it's not fair from Radu, and you answer that properly. So that was my question, really, about the fund application. I have a very quick question about the position. I mean, we were talking about making the HRM, the manometry, in the lying position and then in the sitting position. Is that question still available for the end of flip, meaning that the patient are lying on the side? Does it change again all the discussion, because we cannot put them in the sitting position? What is your answer with that?
So fortunately, that's one of the few standardized things that it's done in the left lateral position. I think what's also important here is that we're looking at a new measure. We look at secondary peristalsis, and we don't look at evoked swallows, but we simply look at the esophagus trying to get rid of the bolus, which is the balloon at that time. So I think we do have a standardized approach, and we're looking at another entity. And it took us a long time for primary peristalsis to get even, I would say, within the community, how useful is a sitting up versus a laying down, because laying down is a little bit more clear, more standardized. And also, I think Radu and me, we did more than 10 years ago, we looked at that, looking at sitting up patients, and we found all kinds of things and didn't find it very specific. This has changed a little bit and with more rigid criteria. But I think for the flip, it's not a problem if it's done in the same position. Looking at patients who are in the OR, who have a different position, who have pneumoperitoneum, who have relaxation and so on, I think all of these placement issues are much more important than for us as gastroenterologists, where we usually do propofol sedation, left lateral position, and I think that's fine. Looking at primary peristalsis, that's how the normal values were gained from the other centers, and I think we're good to go. And maybe adding one more thing, I can differentiate a lynx from a residual muscle, but a phenoplication, depending on whether you use a net or how tight it is, or is it just soft tissue around the flap, it's not the same as a lynx. But in lynx, and I've done a number of post-lynx patients, you can clearly tell where the lynx is or whether it's a non-lynx related problem. And for phenoplication, I think it's not so easy.
Okay, thank you very much.
Then Ioannis has a question as well.
Hi. So I have a very, very short comment about the Radu's question, which was really interesting. So I just wanted to say that in my mind, I don't have any data to support this. In my mind, when we are dilating a foot application, I don't think we are trying to tear the stitches there, or the sutures, but we are trying to stimulate, so to make the tissue actually larger, like we're doing, for example, in the colon after an over-the-scope clip that causes a stenosis, and then we're dilating, we're not tearing the clip, but the colon itself, after some dilations, becomes larger and larger. And I used to think of it about the stomach getting stimulated by eating. So if somebody eats more and more, the stomach has a certain plasticity, so it grows bigger and bigger. And maybe that's what happens also in the junction when we dilate the fundoplication. So the tissue actually gets bigger because we know it works. I don't know how, so I can't explain it, but we know it works. Maybe that could be a possible explanation. But like I said, I don't have data to support it. So my question to Daniel will be, Daniel, you showed in the end the slide that with your personal workup of the dysphagia, which I think everybody that is doing endoflip likes to do it up front with the first gastroscopy. And you showed practically that mostly you do it up front. And if not, then many of the patients having a manometry will eventually need an endoflip to clear up what is exactly happening there. So my question would be, how many of the patients that you're practically scoping for dysphagia and doing an endoflip up front will end up having a manometry? So it's the opposite.
So
I mean, in my head, do we need manometry in the end for dysphagia?
So
of course we do. But
I may give progressive talks, but I'm a conservative person in the end. And what I do is all patients, if it's anyhow possible, get an HRM first. And usually the patients have been scoped outside, obviously, before they come to be seen by me, right?
Yes.
So I first do an HRM before I scope them again and do a flip. So I don't see initial dysphagia, or very rarely. Usually they come, well, yes, I do have primary care physicians that send me to. But if I do that, then somebody else sees it because my clinic is full with flip on other things. So somebody else will scope them and they will check biopsies. We get the results, perfect. No EOE, and then they come to us. But I like to still follow the traditional route of the first doing HRM. If I don't, and then you go on the right side of my talk. I guess you could do an NFLIP in all dysphagic patients right up front. I don't think that the data are fully there yet. I still believe that HRM is what we all best understand. It doesn't have gray zones, but they're not as large as if I would primarily do an NFLIP. So I really like it the other way around. And I would not change my practice right now. So I still do the HRM first. And if it's not possible, then obviously as an alternative, the NFLIP. And in all of the patients, and that's enough in my case, that have questionable results, that have EJOO, that don't have a clear-cut diagnosis, but they're symptomatic, then I do the flip. And I think that's the current role of flip.
Thank you.
Okay, Lucas?
I can't see any more questions. I also think that we've reached the hour mark some minutes ago during the stimulating discussion. I think I would like to thank the presenters for their insightful talks and their overviews. Isabella, again, for her support in organizing this, and also LaserMed for sponsoring this event. From my side, I would like to just tease the next webinar that's planned for the 18th of January, where we will go the next step and focus on the therapeutic approach, focusing on the entity of achalasia. And there we really want to highlight the treatment approaches of Pohl dilatation and surgery, with a varied panel of speakers that are yet to be defined. Please stay tuned on the channels that you have heard of this talk. Also SwissNGM.ch. We will publish all the details, and the link will be available again through the email that you have received this link. That's it from my side. I don't know if you have concluding remarks, Daniel.
No, I'd like to thank LaserMed again for sponsoring that. I'd like to thank you all for your interest and the vivid discussion. Also, thank you, Ioannis, for an excellent talk, and Lucas for helping organizing and putting this all together. Again, we are planning to do this roughly maybe 4 times a year. And maybe at some point we also do some cases that can be discussed, or you can bring cases. So this was a starting point. And again, thank you all for joining, and for LaserMed being able to help us with this, and we are very grateful for that.